Welcome, everyone. We're so glad that you are tuning in for something I know that many of you are very interested in. And we've got a fabulous panel today. I'd like to open with prayer, and then I'll say a few things, and then we'll get started. The Lord be with you. Let us pray. St. Ignatius calls us to go forth and set the world on fire. We embrace this metaphor because we believe our purpose is inextricably linked to helping others clarify and attain theirs. But how do we set our world on fire in this age of sickness, uncertainty, and fear? How do we serve and lead when we are disconnected from each other and the physical space that unifies our team? Who will show us how to press on? Lives perish while the flames of leaders around us dance erratically in the blistering winds of change. Their lights flicker to near extinction. Their sparks, barely visible, struggle to light the way. We cannot wait for them to lead. Let us turn to our God and to the sacred light of the Holy Spirit that burns in each of us. Let our spirits draw closer to each other in spite of the distance between us and march boldly into tomorrow. Maybe it helps to imagine this time as a dousing of gasoline tossed onto our already steady burning flames of purpose and love. Let this accelerant consume and quicken us for the greater good. Shine on, my friends. May the bright flames of our spirits burning in unison create a bonfire that sparks hope, ignites faith, illuminates love, and lights the way. In this uncertain age, a time when our brothers, sisters, siblings yearn for peace and light, we are called and stand ready to do more than we did before, to burn brighter. Gracious and loving God, may it be so. Amen. I want to welcome our panelists. I would love it if they would introduce themselves, and then I just have one other word to say before I turn it over to them to lead us the rest of the way. Steve, would you start?
Yeah, good afternoon, everyone. This is Steve Thomason. I serve as Dean at St. Mark's Cathedral in Seattle, and am also a licensed physician in the second arena that I've been asked to participate as a panelist today.
Thank you, Bryan.
Good afternoon, everyone. My name is Bryan Krislock. I'm the Vice Chancellor of the Diocese, which, for those of you who are not familiar with church speak, means I'm one of the diocesan attorneys.
All right, Judy.
Hi, everyone. And I'm Judy Andrews, and I serve as the Chancellor of the Diocese, as Bryan explained, sort of like General Counsel. And I've been serving in that role for over 10 years. And I also I practice in the area of nonprofit organizations in the city of Seattle.
And I just personally don't know what I'd do with without all three of these people in my life and in the life of this diocese. They are wonderful assets, and we're glad to have them all here today. I'm your bishop. Most of you know that. And I'm going to be on the panel as basically just to respond to the gathering document that we put out on May 7th, as this really, as I said in the letter when we put it out, it would change almost immediately, and it certainly has. I want to say that people that sent questions in, I have your questions. There's no need for you to type them in Q&A again, unless you just really want to, because I will make sure that we get to those. I just got a few, but I do have those, and I want to make sure that you know that. I also want to thank behind the scenes, Carrie Allman, who you saw and heard in the beginning, our internet strategist at the Office of the Bishop, and also April Caballero, who's my trusty executive assistant who's on here to keep us all on track. I thank them both for joining us today and helping us with this. Judy, I turn it over to you.
Thank you so much. So we're going to begin with just a bit of introduction, and then we're going to shift to Steve to fill us in on some really useful medical information about COVID. So I think, Bryan, you have to shift the slides. Thank you. So As I'm sure you all know, our governor has developed, with the help of experts, a phased-in approach in reopening the state. And so this little chart on the slides, and the slides will be available for all of you to have, indicates the various phases that we'll be walking through in order to fully reopen. So then on the next slide, the Diocese of Olympia has really used that phased-in approach as the basis for our approach in reopening. And so we also are in 4 phases, and in each phase follows closely the model that was set by the state, which is based on all of the information that we have about COVID and its progress through our population. So, so we're going to be, as we start approaching phases in which we can start reopening, and I know different counties in Western Washington are in different places, we'll be talking about the steps to take. So this is a colored illustration of where we are in Washington State by county in terms of phases. And as I said, King County is still in phase 1, maybe 1-ish A, and most of the rest of Western Washington is in phase 2. So I'm going to hand it over to Steve, who's going to be talking about medical considerations and regathering.
Thank you, Judy, and we'll just go on to the next slide. And I have several slides. Again, we'll be sharing these with you. There's a lot of information on here. The intent is not to go through it all specifically line by line at this point, but to know that first, there is a lot of information barraging our computers and our desktops day by day, and it seems to be a shifting science. And so we want to talk a bit about that and how things are developing over time. First, just a few brief things about the virus itself. The virus is actually known as SARS-CoV-2 virus, and the infection or disease that it causes is known as COVID-19. But for our purposes today, we're going to blend those two. And if I say COVID-19, we know that we're talking about the virus that causes the infection. It's an RNA virus that is in the same family of coronaviruses as SARS and Mideast respiratory syndrome and several common cold varieties of the coronavirus. It binds to the same protein receptor. That's how it gets into cells. It's the angiotensin converting enzyme 2 receptor. It's the same one as SARS. Therefore, that's why it's called SARS coronavirus 2 or CoV-2. And those receptors are found principally in the lung, in the intestines, and in blood vessel walls. And that will become important here in a moment as we talk about the various syndromes that are caused by it. The virus we know is mutating. The virus that came from China to the west coast of the US has one genetic template, and the ones that came through Europe and then to the east coast has something different, and it continues to mutate. That is going to have implications over time, because vaccines and immunity, either through infection, building up antibodies, or building up antibodies through a vaccination, if the virus mutates frequently, then we have a less effective chance of getting immunity across what is known as herd immunity and individual immunity as well. We do know that there is asymptomatic transmission. There's quite a bit of a hoopla in the last 24 hours about someone from the World Health Organization trying to downplay that. They've walked that statement back. We do know that you can be asymptomatic and infectious at the same time. Next slide. Just to hit the highlights, these are several studies that we've cited across the top, but across the left-hand side, you see the typical syndrome and symptoms of fever, myalgias or body aches, headache, Rhinorrhea is runny nose, sore throat. Dyspnea is shortness of breath, chest tightness, cough, sputum production. Hemoptysis is bloody sputum production or cough, nausea and vomiting and diarrhea. And this last piece of the gastrointestinal is somewhat less well known, that coronavirus isn't just specifically an infection that affects the respiratory system, although it is that predominantly. Next slide. So the pathophysiology of the infection is principally three categories, three buckets, if you will. The hypoxemic respiratory distress and respiratory failure. That's when the oxygen level drops and someone is not able to sustain a proper body function. That's been the primary cause of death for most people, or at least the trajectory for most people that have led to death, over 110,000 now here in the US. A second syndrome is a cytokine storm. Think of it as your immune system is attacking your own body in a just overwhelming way. And then the third is hypercoagulation within your own bloodstream. Things just begin to clot. And we know that stroke syndromes and a multi-organ system collapse are being reported. And just to name that, high-risk groups, those with underlying chronic illnesses and those over the age of 65 now, according to the CDC. It was earlier here in King County and state of Washington, 60, but it's now identified as 65 or above are high-risk groups. It's sometimes downplayed that young adults and children are not impacted by this disease, but in fact, people under the age of 40, the total number of deaths to date here in the US from COVID-19 is right at the same number of people who died altogether in the collapse of the Twin Towers on September 11th. So this is not an inconsequential disease for young adults or for children either. Next slide. We know the modes of transmission are primarily airborne and also contact, what we call fomite to face. And let me describe this some. So the diagram has several different ways of respiratory or airborne transmission of the disease. There can be the ballistic spray from literally just talking. And you know, when you talk, especially vigorously or singing, you're actually producing spit. There's also the coarse aerosolized particles and then fine aerosolized particles. And then there's also the fomite. The fomite is the red thing that the first person is handing off to the second. And assuming that the first person is infectious, the chances of them conveying viral particles that can lead to infection in a second person are extremely high. And the next slide will actually show that in a more graphic detail. So I've darkened this some so that you can pick up what is the imagery of they attached a radiographic element to catch all the different areas. Someone sitting at the table on your left is just having their hands on the table and assuming that this person is infectious and is producing viral particles. The things that they touch there, that's the fomite to face contact, and then moving over to the sink, hands on the sink, producing particles that hit the wall or the mirror in front of the sink, touching the tap of the sink. All of those areas then become potential sources of infection, along with, if you can barely make out on the floor, is where the person has likely walked through their own aerosolized settling on the ground of viral particles and then transmits that into other areas. We're belaboring this because this becomes a significant element, and I apologize, there's an ambulance going by if you heard that. This becomes a significant element and challenge for us as we think about our spaces of worship and meeting spaces, childcare spaces, and so forth. Next slide. Just briefly, and again, you'll have these slides for the details, but ideally, we look at very specific kinds of studies to make informed decisions about diseases such as COVID-19. But the reality is that we have precious few randomized controlled studies or trials, RCTs we'll call them. And so what we're having to do, public health officials and other people in healthcare are having to use lesser forms of clinical studies in order to draw conclusions, even though that would not be normative or considered a peer-reviewed appropriate way to conduct medical decision-making. But what we know is that we're having to use case control studies and cross-sectional studies and case reports to make some of these suggestions, which is why we keep seeing the landscape change daily, is because one case report, which was not intended to draw a conclusion, makes it into the media and into the popular press as being conclusive, when in fact it was just intended to draw a correlation with further investigation needed, and then further investigation finds something different. But randomized controlled trials are the gold standard, and we'll move to the next slide. We have very few of these because they require that some will get treatment aimed at relieving the symptoms of COVID-19, and others in the study will not get it. And you can imagine how that becomes an ethical dilemma in a pandemic. It's also double-blinded so that patients don't know if they're getting treatment or if they're getting placebo. And the clinicians and the researchers don't know whether a particular patient is getting a treatment or placebo. And so there's all sorts of inherent challenges to developing randomized controlled trials, RCTs, in a pandemic. And yet we're trying to make our decisions across the board with lesser models of investigative procedures. So next slide. So we have these case reports, we have cross-sectional studies, we have laboratory observations, and we're drawing conclusions when that would not normally be the appropriate way of approaching public health parameters. We're making our best guesses day by day and week by week, and it's shifting over time. We're going to continue to see adjustments in the recommendations over time, which means that if you're developing plans to reopen your church here in mid-June, but it's not going to happen until mid-August, your plans in mid-June may be very different in detail come mid-August, for example. We do know that there are some things that are translatable from what we know as sound science. So for example, 70% alcohol prep on the hands reduces infectious agents. We know that from other randomized controlled trials. We know that wiping down common use surfaces reduces rates of transmission. We're able to extrapolate what we know about influenza virus and SARS and MERS and others and apply it to this pandemic with the assumption that there are similar patterns for us to go. Next slide. But most of what we are doing is what we call in vitro investigation, which is in the laboratory, versus in vivo, which is actually clinically live patients in the situation in which they have coronavirus infection or they don't, and we would identify how to treat those patients as a result of that. You'll see here, just as an example graphically, that this is the way that we're now saying that there are aerosolized particles in transmission. It has nothing to do with whether we actually know that aerosolized particles cause specific COVID infection. We just don't know that. We assume that that's the case because with investigative trials like this, people are breathing into a funnel and they're capturing what they are identifying as aerosolized particles in the laboratory. So let's pause there and have a brief poll. We know that there are now tests available for us for acute COVID-19 viral infection. And the problem is that there can be false negatives on that test. So a false negative would mean a person has infection and can be infectious, but the test still says it's negative. So we're going to put up a poll, and I want you to answer what percentage of the tests that are being done for an active acute COVID-19 infection, what percentage do you think are false negatives? Think to yourself, someone's posted 25% here. Think to yourself, is it a very low number of false negatives, a very high number? And we'll move on to the next slide. So the reliability of this test is actually really, really poor in the sense that it has a fairly good false positive rate, which means that there are very few false positives. It's not going to tell you you have the infection if you don't really have the infection, but its false negative rate is actually terrible. This is a study out of Annals of Internal Medicine published just about 2 weeks ago, and it's looking at the acute PCR testing for COVID-19. And they know that every one of the people in this study actually were infected, and they did on day 1 of the infection, day 4 of the infection, day 8 of the infection, day 21 of the infection. And on day 1, 100% of them tested negative, even though they had the disease. Now that makes sense. The virus just hadn't built up its viral load yet. But on day 4, 67% of the people tested that were known to have infection tested negative. It drops to 20% on day 8, and then it increases back to 2/3 again by day 21, which is to say that there has been some statement in the media that you just need to go get a negative test, and if it's negative, then you're okay to move on about your business. But in fact, that is not the case. It's going to require serial testing over a period of 14 to 21 days. The gold standard right now is saying probably 4 tests over that time if you think that you have been exposed. Next slide. Let's talk about singing. Singing has gotten quite a bad rap. It's a shifting science. We do know that aerosolized viral particles exist in vitro, again in the laboratory, but there have been no random controlled trials demonstrating infection by this route of transmission. It's not to say it doesn't happen, we just don't have any studies that say that it does. The governor has declared that no choirs will sing in phase 2, but singing by the congregation is allowed as long as they wear masks. Part of the problem is that many of you may have participated in the ACDA NATS seminar of professional musicians in early May, which dramatically overreached its conclusions with really poor science to back it up. And it declared that singing is unsafe, when in fact that is just simply not the case. Subsequent studies have shown that singers can safely distance, depending on the study you look at, anywhere from 5 or 6 feet to 15 feet. There's a candle test. There's a candle test that you can take a look at. And Jason Anderson, the director of Comp and Choir and the director of music at All Saints, or St. Michael's and All Saints, All Angels in Issaquah, is the one who shared this with me. I'm putting a YouTube link in your chat box. Don't open it right now, but you can do so before we finish off, and we'll save the chat to be shared as well. There is a candle test that actually demonstrates that singing is safe at a certain distance based on how the airflow moves the candle test. But here's the important thing to remember is that regardless of where we end up striking the appropriate distance for singing, room environment is as critical a part of the equation as anything else, as wearing masks, as distancing, as anything else. And so we're going to talk about that for just a moment. Next slide. Let me first say that you've probably heard about the Skagit Valley Choir super spreading incident that happened in early March. There is a good CDC paper on this. That's the link that's there. You can get it when we get the slides out to you. but know that the cause of the super spreading incident there does not appear to be singing. It appears to be related to the multiple failures of appropriate room environment, appropriate social distancing and screening. There was shared food, which are fomites and handling of chairs that transmitted infection. There were high-risk group participants in the mix, and they were singing in close proximity, in some cases less than 6 inches apart, chair to chair. And the poor ventilation in the room, they determined that there were only 0.5 air exchanges per hour in that room where the singing occurred. And they've since estimated if they could have gotten 9 exchanges per hour with their HVAC system, the infection rate would have dropped from 70%, which is what it was, down to an estimated 14%. Still not great. You've got to do all these other things. But singing does not seem to be the primary problem, even though we're going to take it very cautiously in the diocese and follow the governor's lead on that as well. Next slide. A German study just hot off the presses in recent 10 days or so said this: air is only set in motion in the immediate vicinity of the mouth when singing. In the case of the professional singer, the experiments showed that at a distance around 0.5 meters, almost no air movement can be detected, regardless of how loud the sound was or what pitch was sung. It is therefore unlikely that the virus could spread beyond this limit via the airflow created during singing. This was not an RCT either, so we're not drawing conclusions off of this that are going to change our singing restrictions at this point, but just know and expect that our singing misses or directives are going to probably shift over time. Next slide. Airflow in closed spaces. These are 2 very busy images, but at the upper left, there is, this is a office space in which there are cubicles, and the airflow coming out of the ventilation system, everywhere where you see the blue squiggly line is how the air flows in that room. And what you can see then is that even with the modules, the walls of the cubicles, the air is being transferred from one cubicle to another. And this, without adequate airflow intervention, would be just the risk of disaster. On the right-hand side is then a meeting room with chairs 6 feet apart. So you're social distancing, but the air comes out of the vent, flows down across the floor. The red just means higher velocity, the blue means lower velocity, but then it just swirls back into the middle of the room, the blue swath across that. And you can see that the person in the chair on the furthest lower right, if they're infectious, are then going to spread it to the people on other parts of the table, even though they're distanced around. So airflow in closed spaces is a real critical piece of what we've got to do in churches in order to be ready to reopen. Next slide. This is just another schematic of a restaurant where you can see in the back of the room, there is a ventilation system with air pouring out, but it pours out and then goes across 3 different tables. And if someone's infectious at the first table, then everyone in that area are at risk of becoming infected. Next slide. So mitigation measures. First, minimize the number of people gathering indoors. You know that inherently. Everyone needs to be wearing masks to protect other people. The masks that we're wearing are not really clinically designed to protect or to prevent the spread of illness. Is to protect one from another. Hygiene practices, social distancing, avoid inline processions. So don't do a procession as you would normally do with a crucifer, choir, other acolytes, chalice bearers, vested clergy, so forth. Don't do inline processions. Minimize air recirculation and increase air ventilation rates. I'll show you a schematic of that in a moment. Consider how you're cleaning the rooms. There's a variety of ways to do that, from fairly inexpensive to very expensive. Consider replacing your HVAC filters with HEPA filters. They have a smaller porous capacity to catch many of the viruses, viral particles, including the ones we're talking about. Ultraviolet C, UVC lighting, which you often see in hospitals, is another way to reduce the number of viral particles floating in the air. And then active screening of participants, which Judy and Bryan are going to speak of here in a few minutes. And then space-specific risk assessment. Look at your space and see how you can modify it to meet your needs for the safety of all involved. Next slide. This is just a schematic that in the upper left, if you had a UVC lamp, on the top left, if you had ways to clean your air and recirculate your air, you might open windows and doors and get fresh air in, the ventilation that is being spoken of there. And then portable air cleaners can be a part of it with HEPA filtration as well. And then obviously all of the individual participant precautions of mask and hand washing and wiping surfaces and so forth. Next slide. So this is a photo of the cathedral. If you've not seen it in the last 4 weeks or so, this is what it looks like as we anticipate preparation for coming back into space. We have the great privilege of having a very cavernous space. We know that our HVAC system, we've tweaked it now with an engineer to increase the exchange rate to a minimum of 10 exchanges per hour, which is really what's recommended at the minimum. We've spread the chairs out. We've removed the pews and spread the chairs where folks will be distancing, and singers, when those are allowed, if and when we reopen, singers will be distanced according to the bishop's directives, the governor's directives, and the science as well. And hopefully those will all align as we unfold to that. But just to give you an image of a way that it's going to feel and look very different for the cathedral, as I know it will in your space as well. And then one last slide before I turn it back. So just a summary. All of the personal precautions to avoid film-to-face transmission, active screening for your gatherings, opt out if you're ill or symptomatic, quarantine if potentially exposed. We have to do contact tracing that goes backward in time if we identify someone who's tested positive after they've been in our space. And then social distancing, of course, and room modifications as we discussed. And then the last slide is be guided by the diocesan document that the bishop and his staff have put together. It's a good document that will guide all of us. And no need to reinvent the wheel. So let me turn it back to Judy and Bryan then.
Okay, thank you, Steve. That was really helpful. That's great. Hi, Bryan. So let's dive into some of the really specifics about reopening churches when we get to that point. And I pointed out in the beginning by looking at the phases that the diocese, the Office of the Bishop, has been monitoring King County Health, Washington State Health, the CDC, and our governor in the White House to get all of the information, and we have decided to mirror the phased-in approach from Washington. And the really important part of this slide is that it's the Office of the Bishop who's going to tell us which phase we're going to be in the diocese, and that local congregations don't have the authority to make that decision on their own. So really important to stay in touch with the diocese in terms of where we are in phases. Okay, next slide. So follow steps for reopening. Follow the directions of a diocese with respect to which phase you're in. And then, actually, I think maybe Bryan, I need to turn it over to you.
Thanks, Judy.
Yeah.
So we have the general diocesan phase guidelines, and then the next stage is once you're ready to move to the next phase, it'll be really critical for your congregation to engage in that local evaluation. of both the size of your congregation, the available space, some of the issues that Steve was talking about with respect to circulation and how much social distancing you can engage in, what your facility looks like, entrances and exits, and then your staff and volunteer resources to address some of those issues. And then once you've done that evaluation, develop your own localized reopening protocols that are consistent with the general guidelines from the diocese. So essentially how your congregation is going to implement the requirements of the diocese and the state with respect to the social distancing and reopening guidelines.
So we're going to spend a few minutes really talking about protocols for reopening space. And we're going to start with preparing your church space. And a lot of this does really refer back to the information that Steve so helpfully provided. So you'll want to deep clean the entire church. So the pews, the doorknobs, the restrooms, the light switches, the stairs, microphones, all of those things really need a deep cleaning. And then the protocol for services is that before and between and after services, you're going to want to clean and disinfect all of the places where people are. So for sure the nave, narthex, before, between and after services. You will want to, before you have people in as a congregation, remove all the books, pens, note papers, and so on from the pews and other things in the space so that there are fewer things to clean and fewer things to touch. How are you going to distribute bulletins? Are you going to have ushers wearing gloves? So that, again, that's not a touching point for people. You'll want to have antibacterial dispensers at every entrance so that people use that as they come in. And have, of course, disposable facial tissues available with waste bins that are no-touch bins to put them in. Everyone should be required to wear masks. I think increasingly people have them and know they need to bring them with them, but you'll want to have a supply available so that if someone comes without a mask, they have the ability to put one on. Really important to protect other people. And then, of course, the issue around restrooms is, do you want to have the restrooms open? And if so, ensuring that you have appropriate protocols to ensure that those are cleaned. And again, cleaned in between and before and after services. I think I'm going to pass it off to you, Bryan. Do you want to move on to staff and volunteers?
So besides the physical space and thinking about the protocols associated with what your physical space looks like, it's also very important that you address staff and volunteers. So everyone knows what the protocols are, is up to speed with what's going on and what the plan is. So one of the first most important steps is going to be training your staff and volunteers in the protocols and the actions and the safety actions relating to your reopening plan. You'll want to consider potentially doing a temperature check on staff and volunteers to see if they have any symptoms associated with COVID-19 or the coronavirus. You'll also want to consider limiting volunteers to those without pre-existing conditions, so high-risk individuals, because your staff and volunteers are probably going to be the most exposed to other individuals. So potentially limit them to those non-high-risk groups. Provide some instructions on greeters on how to greet. No handshakes or hugs. I know this is hard because we're so used to, especially when it comes to new visitors or old familiar friends and family, to give them a handshake or hug. But part of the act of being there for the other and loving our neighbors in these circumstances is to not do that. Maybe potentially have the greeters hold the doors open. So that way you're limiting contact with physical surfaces. If you recall from the earlier presentation about how the virus can attach to certain services. So maybe think about how your greeters can facilitate that. And then also provide the ushers the authority and the training to enforce the guidelines in a very loving manner, so that there's gentle reminders out there with respect to social distancing protocols.
Masks. So ushers we should have the authority to make people wear masks. Go ahead, Greg.
Yeah, I was going to add that, and we'll talk about that more, but also that you can see these inconsistencies in our original reopening document. We said 60, but as Steve had said, that's been changed by CDC to 65. So we're going with the 65 number now. I just wanted to go ahead and get that question cleared up before anybody asks it. So thanks a lot, Bryan. And
then the next portion, so you have your physical space, you have your staff and your volunteers trained. The other aspect to think about is how are you going to design your worship or the program that's opened up. Some things to consider, both in line with the diocesan guidelines and then also your own internal planning, is you want to consider and you'd be encouraged to continue keeping online worship for those who are vulnerable or afraid to come in person, especially that, since we're such a transitional time, it can feel very difficult for someone who might be a high-risk person who can't come to be with their church community. So keeping that option available for people to participate would be really important. And it also would provide an avenue for people who are high risk that feel the need to participate in worship in some way with their local congregation to be able to do that without feeling the only option is to show up in person. So it's a way to encourage people to stay home and keep distance if they need to or should. Plan, as Steve showed with the Cathedral, plan seating to distance people 6 feet or more apart. And ways to do that, at our law firm, one of the things we did is we put actual signs, like if you don't have chairs, if you're stuck with only having pews, maybe consider measuring out so people know where to sit, so that there's spaces where they can't sit to help encourage that social distancing. Also consider maybe moving to a multiple service model on Sundays. So instead of the traditional 1 or 2 services, maybe consider having 3 or 4 services with fewer attendees, and consider different ways to approach, encourage, I know some of the ways to encourage certain groups attending different services who might be higher risk. So you kind of mitigate some of the exposure. You can have people sign up for services in advance to encourage, adequate control of the number of people who are attending. Assigning fixed seating, as we discussed before. Maybe consider outdoor services. I mean, if you're considering airflow in confined space versus out in a courtyard, there's a lot more airflow and a lot less risk that the virus gets recirculated in a confined space if it's outdoors. Again, continuing virtual worship and smaller choirs. And then also consider, as you're thinking about bulletins, or hymnals, consider maybe projecting announcements or hymns on a screen, so that way there's less physical contact. And then other aspects to consider too, and some of the things we don't really think about is, a dismissal. It's typical for a congregation to end its service. We do our procession, we do the dismissal, we go forth into the world, and everyone comes and greets the priest or the rector or vicar or presider. That's an opportunity for the virus to spread in a very confined space. So think about your exit strategy. How are people going to leave the space so they're not confined, going in a single file line out the front of the church? And also look at, stations for offerings and giving, continuing online giving, Venmo, other options are available for congregations to have people donate just right from their phone at the offertory instead of having to physically put cash in a plate that's past, but having that station set up and encouraging people to take advantage of those options. And then as far as, Eucharist, we have the diocesan guidelines with respect to what can and can't be offered at certain phases. And the conditions for phase 3, no common cup. Bread may be shared with only one person distributing and doing everything in their power not to make physical contact with the recipient. Again, being mindful of paying attention to when contact is made, sanitizing, having hand sanitizer available, and then ensuring that there's an abundance of sanitizer. So it's kind of the new purificator approach if we take old approaches and old traditions and adapting them to new environments.
So communication is really important, particularly advanced communication, because there are going to be lots of changes for members to be aware of before they come, and it's always better to know it before you come. So putting it out there in all of the various ways in which the members of your congregation receive and get communication. Facebook, your website, any newsletters that are sent out by email or in other ways. And obviously for some people who, like my mother, did not have any computer at all, mail would be really helpful. Having clear signage in the facility, so in the entrance, as people walk in, wherever it's appropriate, at restrooms, reminding people about good hygiene, reminding them about masks. You may definitely want to consider having a sign-in so that you know who's attending that week in case you decide to participate in the contacts that need to be made if someone does come with and has COVID, so that we have a way to do contact follow-up. Considering the most important messages that need to be made, and then and alternate ways for those to participate who can't attend for any one of the reasons we've discussed, particularly if they are part of a vulnerable population. And it's important, the other thing important to put in the communication is, if you're sick, please stay home. Really, really important for people to be cautious about that.
And one quick thing to add, Judy, and we'll circulate this. Both the Department of Health and the CDC has some pre-made posters that can be made that communicate those messages. So there's posters you can just download, print on any color printer or laser printer, and they're ready to go. You don't have to reinvent the wheel necessarily. So we can give you a link to some of those state and federal resources.
And if you have employees, there are actual state things that you need to print and post in your office as well. So if you aren't aware of those and need a reference, please either contact Bryan or me. So childcare. So the first consideration is consider delaying reopening childcare for a while if you can. When you do open it, it's really important to think about the kinds of protocols we've talked about. And some particular considerations with respect to childcare are, you might want to pre-register children so that you have a way to limit the number of children in a room. Children are harder to socially distance, and so having fewer of them in a room is really helpful. You'll want to limit folks who are in the children's areas to ensure that those who are part of the vulnerable population are not there. Have a list of what's been cleaned and when in each room so that you can assure that you're using and doing your appropriate cleaning protocols before and after those rooms are used. And just a note that the American Academy of Pediatrics recommends that children 2 years and younger do not wear masks or face coverings. But of course, we would prefer that other children who are older do wear masks. And then also just a reminder that even with all of these special protocols, we do need to make sure that we follow the safeguarding rules. So we want to make sure there are 2 unrelated adults in each of the rooms that are used for children. If you have renters or shared or other users and other congregations who use your facility, you also need to think about their use of the facility and when they can return, and ensuring that they are following appropriate protocols as well. The timing of the return to the church buildings or facilities is something you'll need to talk about with each renter. You are the owner of the building and you can say no if it's too early. And if you aren't comfortable with the protocols that they're following. You'll want to take a look at the lease or rental agreement or use agreement that you have to ensure that you have an appropriate indemnification provision and that they are required to have insurance and that you're an additional insured on their insurance policy. And of course, you'll want to make sure you check your insurance policy as well. We want to make sure that you're protected in case something goes wrong and there is a breakout. You will want to know what their protocols are and review them to get comfortable that they're following the CDC and the diocesan protocols. And of course, you also want to encourage organizations to have appropriate provisions for vulnerable people who may be using their facilities in particular. And we wanted to go through the list of the folks who are at high risk. And as Greg and Steve have pointed out, it's now 60 people who are 65 years or older. And then I'm not going to recite all of these, but just be aware that if folks are in nursing homes or long-term care facilities, they're considered vulnerable. And then there are underlying medical conditions that we've listed here that also lead to vulnerability, particularly if those conditions aren't well controlled or are really serious with respect to that particular individual. So just so you have that list and are aware of who the CDC has defined as those at risk for severe illness. And then it's really important to think about what you can offer those vulnerable folks. So if you have staff who are at higher risk, you'll need to offer options, longer time working at home perhaps, or ways in which they can be in the facility and be particularly protected, an office space of their own, for example. Offering options to your congregants who are at higher risk for severe illness, continuing remote participation, so online streaming, and maybe having special services in which fewer people are present and there are more, there's more distance and more protections with respect to social distancing and cleaning and other ways to protect those individuals. And then, of course, ensuring that you are consistent with federal and state law regulations and have policies in place to protect the privacy and confidentiality of those who are at risk for severe illness because of underlying medical conditions. So just be aware that while you may know what that is, it's not really appropriate to be sharing that with others, that it is something that is protected under privacy laws.
So one of the questions that we get as lawyers most often is how do we protect ourselves against legal liability in the event that someone does get infected or that there is an outbreak in your congregation? So first and most importantly is that a congregation or church's primary protection will be from their insurance carrier. So whatever policy you have generally includes, and it should include, a commercial general liability policy, which covers negligence up to a certain threshold. So it would be important to review your current insurance policies to ensure that there's adequate coverage in the event of any kind of claim, and that there are no exclusions that would prohibit or limit your ability to hold gatherings. Also equally important is that you're following both Department of Health, CDC, and diocesan guidelines. Oftentimes a claim for liability will come if there is a deviation from whatever the official guidelines or protocols are. And then also that your own protocol is being followed. So this comes back to the training of staff and the planning to make sure that you have a consistent, well thought out protocol that minimizes the risk and ensures that you're having adequate protections in place and that you're following it. It's not just having one, but it's also implementing it and using it. Also consider the signage and announcements in both your communications that requests people that stay away if they're meeting the risk guidelines that were shared earlier, or that if they have symptoms or have been exposed to the virus or a high risk potential carrier. Offer them suggestions on other ways they can participate. So this is why you want to continue to offer alternative online remote worship opportunities. So it's both, it's not just a stay away, it's also here's something else you can do to participate in our community. And then consider requiring consent or a sign-up sheet when they arrive to share information with the Department of Health for contact tracing. So one of the, you may have heard is there may be some robust contract, hopefully, tracing programs in place. We're not really sure, but it's important that we're able to communicate with people who might be exposed and may need to get tested, so we can contain any outbreak that originates in one of our churches or congregations. But our hope is that if we follow these guidelines and we follow the protocols, that won't be happening.
Can I just add a quick thing? I think it's important, we talk about the protocols, it's important that you write down the protocols so that as part of training, that you have an individual that's responsible or a group of individuals that's responsible, that they have it in writing so that those protocols are followed each time. Because that's part of, if something does go wrong, that's part of your defense. We have the protocols. We appropriately follow them. People were trained. So it's really important to go through those steps and to make sure that those protocols, each one is followed each time for a service, for example.
And that the protocols are consistent and not inconsistent with the signage and the communication. So if you have a protocol in place that says X, that needs to match the signs and match the practice versus inconsistent messages.
And it is important for your ushers to be able to follow up with people and enforce the protocols that are necessary to be called, that are followed by the members of your congregation who are present. Oh, and so I'm on this next slide. So what happens if you discover that your clergy or a person or a staff person or a congregation member has COVID and actually was at a service on Sunday, or finds that they have some symptoms while they're at your facility working or at a service? So it's really important to, if someone has symptoms of COVID during the hours of operation, make sure that they go someplace that is separate while they're waiting to go home, and ensure that if they have children that they have adult supervision. You really want to have procedures that you've thought about beforehand to make sure that if someone is sick, that they have a way to get to home or get to their healthcare facility. You'll want to notify local health insurance if the person is diagnosed with COVID who's been in your facility. You'll want to communicate with staff and congregants about potential exposure, although you won't want to name that person because of confidentiality rules. And then, of course, to the extent that folks may have been in the vicinity of that person, or depending on the size of your congregation, then quarantine, of course, is going to be an appropriate response. And then, of course, following CDC guidance if you in turn have symptoms. And then if the person, this is true particularly for staff, if the person was in their office, then ensure that that area is fully cleaned and disinfected before you open it up to other people. And then, of course, just a warning to be careful of disinfectants and using them appropriately and keeping those products away from children. Advising staff and congregants that have symptoms of COVID or tested positive not to return to church until they've met the CDC's criteria by staying in quarantine, by home isolation. And then we've listed some resources for you that you'll be able to link to when you receive the slides. And there's just a few of the many, many resources that are available. And I think we're going to spend some time now with questions and answers. So, Greg, are you going to be?
I'm coming. Yes, I'm coming
Yes.
back. Yes, I am.
Excellent.
I'm going to lead us through these. People, do not worry. All your questions are here. We just let panelists see them. In fact, I believe there are 47 questions, so we might be here until next Thursday, but we're going to try to get through here. So I'm going to start through these. Many of these were answered, but you could add questions that you have. And I'm going to answer from the standpoint of the bishop and being the bishop and the document that we put out and how some of that has changed. Some of the ones that were emailed to me were about special liability issues regarding outside groups. I think that was just addressed in what was seen here. There is a question here about hospitality, like coffee hour and things like that. I would say, from my standpoint, those are not going to happen for a while.
Yes,
So we will worship and you will go home. So what you need to do is do what Bryan was talking about, and that is decide how you're going to dismiss and keep social distancing. And that really will be the last moment you're in the church for quite a while. So that's the answer to that. There was a lot of another question about liability, but I do think we've covered that. But I do want to say, and I'm going to ask the panelists myself, if we will be putting out a sample consent form that might also cover the questionnaire questions like, are you feeling well today? Have you traveled anywhere that you shouldn't have? All that kind of stuff, so that we have one sheet that people could use. And you could also use this for contact tracing. I see nodding by our two attorneys. So we'll be putting out a sample consent so that you all have some way to something you could copy and use fairly quickly. And it can cover a lot of these things. If you keep those for 21 days, you'll have contact tracing information too. So we'll try to cover all of those with that.
Greg?
First, yeah.
I would just add that we've added a question to our screening questionnaire for people entering the building in light of the protests that have been going on that are not socially distancing. We're asking the question, have you participated in any gathering in which social distancing was not observed? And it doesn't automatically disqualify someone from coming in the building, but it gives us pause to investigate further about what that activity was. And that would include being in someone else's backyard or visiting someone too.
Very good point. In fact, recently I went on a virtual visitation, but it was real for me. And we actually did confirmations. It was a small enough group that we could pull that off. And one of them called me the night before and said, I want to go to this protest. Will you still come and do confirmation tomorrow if I do? And I said no, because I think that kind of, as much as I wanted her to go and me to go, the problem with that is that I'd be carrying that into, and she would too, be carrying that into that space. So trying to keep it safe. So I think that that's a good point, Steve. A question that I didn't think about or get to submit beforehand, can we get some specific guidance about 12-step groups and phases at the appropriate time? I've been answering this from several people. Pretty much we follow the guidelines for whatever is true for you as your church. So, but if you're in doubt, people are checking with me every day. You can, but I think they need to be expected to follow all the guidelines you're following. They have to wear masks, all of that. As long as they do that and we're in the phase where you can do that, then it's fine to welcome them back. And of course, disinfecting before and after the meetings and all of that. Could the bishop and the panelists respond to the issue of at-risk people? This is a good question. I want to be really clear about this. I think I've visited people, of course, by Zoom, and some also in person. And there seems to be this belief out there that we're going to bar people at the door, wrestle them to the ground if they're 65 or they somehow disclose to us they have an underlying condition. I'm not sure we're going to be able to do that. The reason for consents are that they may take the risk themselves, being over 65, to come into the church. We don't think the ushers, we're not trying to turn them into policemen, or people are you're gonna have to make an individual choice whether you return. And at least for me, I'm not expecting you to be enforcing that, but this is why I think a consent form is so important, because if they choose to put themselves at risk, I think that that's something we're not going to be able to control. Many of you in these questions have pointed out that our demographic is 65 and older in many ways. And that's one reason to really consider. Another question that I see in here about whether you should be conservative in coming back. And I think you should be. And I want to make clear what I've said to anybody that's asked me, is that just because we're in a phase that you can go to, it is not my expectation that you have to go to it. So just because we got into phase 3, and in phase 3 you could meet, if you don't feel comfortable that you're ready to meet, or your people aren't, you don't have to. So you can, but you don't have to. As far as liability, I'd also want to say, and the attorneys can jump in on this as well, but I would say the answer I was always given in healthcare, and even in this role, is that anybody can sue you about anything. If they have enough money and an attorney that's willing to do it, they will. So there's no way to mitigate that completely. What you can do always is to do the best you can do to show that you did due diligence, and that these people of their own free will decided to come into a space, even if you said it probably wasn't a good idea. You know, there are no guarantees in this. I don't know of a lawsuit yet about this, but I'm sure there'll be one, and we'll learn more about that too. But it's hard to tell for sure on that. Okay. Yeah, go ahead.
I would just like, as one of the lawyers, I would just like to add. Greg, you answered that exactly right, and I just wanted to say one more time that having written protocols that everybody knows about and everybody follows is your best defense for anything like that.
Yeah, thank you. Question here, any more information on the vascular inflammatory syndrome affecting children post-COVID infection? Steve, any more than what we know, or briefly?
A lot of investigation going on it, but I think for our purposes today, just to say that this is not a disease confined to the elderly. It obviously it infects and affects the elderly in a statistically significant way, but children are affected, and the Kawasaki disease type syndrome that they're speaking of is a very real entity, and we just don't know a lot about it yet.
Thank you. That's good. The next question, I'm seeing in the news today that several states that had been among the first to relax their restrictions are now seeing an increase, especially Arizona, but several others too. That seems to suggest that there is wisdom in being conservative about setting a date to reopen buildings. Yes, well, I think I just answered that. You can choose there not to do that, and I think you should poll your people and make a decision about whether you want to start live worship or not. Choral singing, I think this is all about, yeah, Joyce, I think you actually said, Joyce, that Steve hit this question and answered it for you, so I'm going to go on. isn't this associated with a particular test that's being used? Aren't some testing systems more reliable than that? Yes, I think Steve answered that one too. A lot of the science that Dean Thomason's citing is so recent that it's not permeated the media. More reason to keep us informed. Thank you. So thank you, Steve. And you know, one of the ones even today, there's been confusion about contact or fomite transmission. A couple of weeks ago, they kind of almost said, you know, that's not the big deal, don't worry about it. But now we're back to maybe we should worry about it. So thank you. Basically, we remain confused, a lot of us, but we just have to keep watching it. So thank you.
And Greg, I would just echo again or repeat again what has been said several times, and that is that this is a moving target. This is a moving target that's going to adapt over time. And I also want to just give a shout out to Jason Anderson, the director of the Compline Choir, who has been down in the weeds on this research and has shared some of what I shared with you, stuff he shared with me, and then others I've gleaned as well. But he's doing a great job of in all the ways that he's serving the church, keeping things safe.
Yeah, thank you. And I wanted to say that even though this research that he shared today seems to say that singing might not be as bad, our document remains as written. And until I say we can sing, we're still not singing. I guess I'm saying I'm not totally convinced yet. So we've got to do it with care, and we'll try to keep you up to date as much as we can. Question: what was the air circulation rate achieved at St. Mark's? That was garbled in transmission. Yes, it was a little bit. Steve, can you answer that again?
Yeah, we're just about 10 cycles per hour in the cathedral nave, which is kind of at the low end of what's recommended by the HVAC engineers, and every church should consider consulting an engineer to help them identify how they can improve airflow and ventilation.
Okay, thank you. This question here: what about clergy over 60? Well, I think I know what you mean by that. We have lots of them. I would answer it that way. I would also say that you really need to take into consideration your health. And if you're worried about going back face to face, to get with our office so that we can talk about what the options are for you. No one should feel forced to go back into this situation, especially if you're in that high risk group. So you should be talking to me or to RAN about your concerns about that. And it would be better to talk about it earlier than later, because one thing we're finding out is the phases kind of jump onto us fairly quickly, and we're there, and we haven't thought through often what we need to do next. So does the disinfect daily and surrounding services require the electrostatic spray or just use of the disinfecting wipes? I think I can answer this. I don't expect electrostatic spray to be something where we have readily available, and we're talking about wiping down with basic disinfectants that CDC requires, bleach and water, things like that they've said that work. What does a deep clean entail? Well, a lot of money. I found that out early on, and you know, but maybe someone else on here wants to talk more about what a deep clean entails. Literally, some of you know this, in the very early days, one of our churches asked a company to do a CDC deep clean, and the quote was $54,000. So we're not talking about that, because none of us can afford that. I think a deep clean is just very careful care that you cover all the surfaces, and that you do that every time your doors are open and people come in and they leave. You have to do it before and after. Any other panelists want to add on to that?
Well, I would say that a deep clean also is, doing your floors, for example. It's maybe not this, you're not going to do the floors every single time after you have a service, but you're going to want to do it with some regularity. And as we saw from the picture that Steve showed us, that the floors can also be I'm not going to use the right word, but they also can be contagious, cause contagiousness, particularly if you have children who are on the floor or touching the floor. So, or if you drop something on the floor. So I think the deep cleaning is all of those things that you really do need to clean with regularity to ensure you're getting all of the benches. For example, at the cathedral, there's lots of things around that you might clean as part of a deep clean, but not necessarily wipe down in between services. So I think that requires really looking, it's all those factors that we talked about, looking at your facility. Is it carpet? Is it, what kind of flooring is it? Do you need to clean all the pews and what you need to wipe down that's different? Taking out things that you don't want to have to clean every time. So it's really doing that kind of analysis for your facility.
All right, thank you. What if your church has no servers, volunteers under 60? I believe we've answered that. You either need to keep meeting virtually, you need to not force anyone to come back, and after you assess that, you're going to have to decide how you're going to meet as a church, either virtually or with some of your people, or no one's being forced to go back and no one's being forced to serve. And that's some of the decision you're going to have to make and some of the work you're going to have to do locally to decide the answer to that question. Will restrooms need cleaning between individuals' use? So this is a good question. Like if one person walks in and walks out, are we saying we're expecting that will be cleaned every time? I do not see how you could.
I don't see how you can, but I would see that if you're going to have the restrooms open, that's what it would go into your decision making, depending on your restroom, as to whether you are going to even have them open. But if you are going to have them open, then for sure you would go in and do a protocol wipe down in between services, and of course after services and before services. And
have all the make sure you've got plenty of soap in there, sanitizer, if that's what you want to, I mean, make sure that that is well equipped with everything that's needed for the people to follow the protocols.
Yeah.
Greg, at the cathedral, we've talked about this in anticipation of reopening, and we're actually going to spend a little bit of money to make all of the taps and flushers touchless. It's going to, for the cathedral with a lot of different bathrooms, it's going to end up being about $3,000 total. And we just feel like it's worth that. We'll probably ask someone to help underwrite that, and other churches can do that as well. It's very easy. We already have touchless hand towel dispensers, but think about the minimum number of ways that people have to touch surfaces.
Thank you. I see a lot of questions going into chat. I'm not going to get to them there. Put them in Q&A. That's what I'm going down. Q&A, not chat. All right, protocol documents still saying under 60. We addressed that. It's 65, not 60, even though we made a mistake. It used to be 60, now it's 65. If someone contracts COVID as a result of being exposed at church, could we be liable? I believe we've answered that. Almost any question we can ask in the world, the answer to that is yes, depending on what a court does. We don't really have cases yet on this, but what we're talking about today is mitigation to try to make that less likely. And by following these and writing the protocol, as Judy and Bryan have said, and being as clear as we can be, and using consent forms and keeping track of those and showing due diligence, we have less likely chance of it, but we can never guarantee that it won't happen. Somebody might do that. How long should we keep tracking health forms? Good question. At least 21 days. That could change too, but right now that's what I'm suggesting. Some I know have already said they're going to keep them 30 days. Part of that's just a little bit easier to do. I don't know why, because you still have to keep up with all the days that you've been there to worship, but 21 days for sure, so that the infection incubation time is covered in case somebody appears and says, I was there. You can certainly keep them longer. And if I were in your shoes, I might keep them for 30 days and then you just have it even longer and you can then get rid of them. What are the legalities of broadcasting parishioners' images once back to in-person worship? Do we need signage saying we broadcast, and by attending you consent to that? Very good question. Before we invest in modest equipment, we want to make sure we can meet the criteria. Thank you. Did we address that? It's a good one.
It is a good one, and we didn't address it. And I believe that if you put up a notice to let people know that you are broadcasting, and that if they're in the way of the camera, they will be on camera, that would be appropriate notice.
Okay, great. The next question is about gloves. It's a good point. Gloves protect the wearer. They do not, and they only protect the wearer if they don't touch their face. And, you know, it's still, it only protects the wearer from getting it directly on their hands. But if they touch their face and the glove is contaminated, they're still contaminated. It doesn't do anything to help the person that they're helping. So this one was directly talking about ushers handing out bulletins. This is one reason we're asking you not to have bulletins. The people that have opened so far, I've said, don't have them. Figure out a way to do worship where you're projecting, or you're just asking them to listen. Or one idea I have allowed one place to do is to put a PDF online and tell them to run it off and bring it with them to the church and not share it with anybody. I hate to say not share, but in this case, probably a good idea. And they have it that way. But bulletins printed and handed out, at least in the first phases, we shouldn't be doing that. If an employee contracts the virus while working, like our sexton, are there liability issues we need to be aware of? If extensive medical care is required, would this be a workers' comp issue?
So if he contracts it at the church, yes. I think that would be the answer. It would be it would be covered by workers' comp. And then but in any event, that person needs to go home or go to the appropriate to get appropriate medical help. The place where that person has been needs to all be cleaned down. And then contact tracing, we need to see who's been in contact with the sexton.
Yeah, I think it would be difficult. That's going to be an interesting thing, because proving that you got it at the church is going to be a hard thing to do.
Exactly.
I think. But it's a good question.
Which is why it's important, one more time, to say that it's really important to have protocols in place so that employees are asked when they come in every day, do you have any symptoms? Please stay home if you're sick. And having written protocols so that you have the ability to catch it right away, and that you've done things to protect yourself from acting negligently with respect to this illness.
Yeah, it's a great point. For instance, if the employee could actually say, and you can't refute it, that, well, they ask me about every 8 days, those questions, but the other 7 days, I just show up and do my work and nobody seems to care. You could be in trouble. Whatever you do, you got to do it consistently and every day and have a protocol that you follow. If our county's in phase 2 by the state and allows up to 50 people in attendance indoors, do we follow phase 2 diocese and wait until phase 3 state until we have? No. On the phases, I told you when I put out the document it would change in about a day, which it did. What we do is we follow the governor's memos. The way he is changing even his phase-in document, what we're really going to have is not phase 2. We're going to have phase 2.1, 2.2, 2.6. That's what we're seeing. And we are trying our best to be on top of those things, so that I'm trying to allow you to go as far as your county has said you can. There may be, in fact, some particular practice that they will allow that I might say no to. But if we do that, we'll be very, very clear about what that is. So far, I can't think of that. People that have moved to phase 2, and for instance, even in King County, he put a memo out that said that you can now meet outside with 100 or fewer people with social distancing. You can also meet inside with 25% capacity. So that's a change from my document, because that changed since that document was put into force. And so I would allow you to go to that limit if that's what you choose to do. So I'm riffing off the governor's plans and changes and trying to allow you to move to that part if you'd like to. Will there be discussion or guidelines? Yeah, go ahead.
I just wanted to add that don't be in a hurry. Take the time you need to do the protocols first, because it's really important that those be in place and that those all be followed before you open, and people be trained, and you have your communication ready, and you've really thought through all these issues. It's one of the reasons we wanted to do this program, because you don't want to be doing these after someone's come to church having COVID. You want to do that.
Yeah, I totally agree. I've got one church that just keeps asking. All they want to do is get together. And they just keep asking and asking. And I can't tell you how many times. And every time I could just repost the email, the same one. I ask them, have you come up with the protocols? Have you done this? Have you done that? The answer is always no. It's just I want to race back to where we were. We're not going to do that without putting all of these things into place we're talking about today. So it's not going to happen. So you can keep asking, but the answer is going to be the same. You've got to do these. You've got a lot of work to do before we can open our doors. Will there be discussion or guidelines for those parishes that have tenants? I think we covered that. If we don't think we did, or you have a specific question about that, add another one on. Can we legally require people to give us contact information if we don't already know how to contact them? I think we can ask of anyone what we want to when they come in the door. I'm getting nods from the attorney. Yes, we can.
Yes, they don't have to give it, but then they can't come.
Yeah, right. That's a whole other issue. And this next one is related to that, I think. Wearing a mask is inconsistent with receiving the bread. How to do? Well, what I've witnessed online is what I'm calling mask fail, that we actually need to do a workshop on how to wear a mask. I see people that have the mask down around their neck or covering their mouth and not their nose, or, as an eye patch. I mean, it's an interesting problem. I don't know. But what happened in Taiwan, I will just answer that, was they were all masked. Everybody was masked. And we took it down long enough to have communion, and then we left and we put the mask back on. But this is one reason why returning to that practice quickly is something you really need to consider because of this very reason. There's no way to do perfection in this. And I just will say again, we've got to be conservative, I would say, about when we move to these things. Governor's modified guidelines for phase 1 and 2 is posted on diocesan website, discusses indoor services during phase 2. I hope this will be discussed, including having communion with such services. Unless he's changed a specific part about the phases, our document still holds. And in phase 2, there is no communion, certainly not the common cup. And so I think that still stands. Phase 3 is the first in our document where you could start having communion. And communion is going to be a piece that doesn't get addressed by the governor and is only addressed by us. He's pretty much gotten away from trying to get into individual practices that we might do. What may come back at some point is water in the fonts, because, and I'd consult Steve and many others on this, but many are now saying that's probably not a real swift way of transmission, especially if we could use some chlorinated water or something like that. But I don't know that yet. I still haven't released that, and I'm not going to right now. There may be no way to respond, but have you words of comfort for congregations that consist primarily of persons over 65? I don't know about words of comfort, except to say that nobody's going to be forced to come back. And what my words of comfort about this have been to clergy especially is that we are going to have to believe, practice, and function as if this will go on a long time, and that we're going to live in two different worlds, virtual and face-to-face. And that may be the biggest decision you all are going to have locally, is how and if and when you do that. It's going to be, I've been saying this, it's going to be more work, as many of us have experienced. We think this would be less tough, but it's more tough. And that's where it's going to get locally more tough, when you're going to have a virtual congregation and a face-to-face congregation. And this may be true for a long time. So yes, that's our demographic. And I think we have to be right now, not just with the legal protocols, but also thinking pastorally how we continue to be the church with that demographic, and still give them safety and connection. It's not an easy thing, but that's what we've got to do. Sign in at the service. How do you do that without touching something, pen or paper? That's a good question. I'll just say what I've seen in some of the retail establishments that I've visited is that they have 2 buckets of pens, and they're marked dirty and clean. And they instruct you to take a pen out of the clean and then put it in the dirty after you've signed. And then somebody cleans the dirty ones and replenishes the 2. Now, Steve may have another better idea about how to do that, but that's what I've seen. And that's, I think, the best we could do at making sure. You could also bring your own pen and use your own pen and not share it with other people. But of course, not everyone's going to do that. So I would offer that as a way to do it. Steve, any other thoughts on that? Or?
Well, certainly the clean and unclean buckets is what a lot of medical facilities are also doing when you sign in. I will tell you that I carry my pen everywhere, and I only use my pen to sign in, and only I am the one touching it. The alternative would be a much more laborious process of getting people in the building, which is that you have appropriately protected individuals who are receiving the information and are the ones writing it down, collecting all that info. As you can imagine, if you're trying to collect not only name, but also contact information and the screening questions, that's going to be laborious.
Thank you. Next question. I think you said that we would be expected to operate contact tracing. Well, I'm not sure we put it quite like that. You won't do the contact tracing. You are required to have the documentation in case that becomes necessary. We're not asking you to do contact tracing. We're asking you to keep records of who's been in your space. So if someone becomes ill and the health department comes and asks you, we've got documentation to show who was in the room with the person that has become, that's what contact tracing is. I'm sure the person that wrote this knows that, but if I understood this correctly, please give more guidance on how to do this. I envisage very significant practical, technical, and even legal difficulties implementing this, given that most governments have not been able to establish this to date. Again, we're not asking you to do contact tracing. We're asking you to keep records. And I don't think it actually should be that hard to do. It'll be one page, and I think our attorneys are going to offer a sample page that will cover the questionnaire, it will cover consent, and that's what you can also hold on to for contact tracing if it becomes necessary. And then you keep that for 21 days, and then you can destroy that. And if people don't want to do that, then they don't have to enter the building. You know, this is a stark thing to think about. We can't, as I said, we can't police all this, and I don't want to turn this into barring people at the door, but I did hear of a priest, another diocese, who has publicly stated that he would expect everyone to have a mask on, and if a person refuses and doesn't have some kind of medical release to do so, he will simply cancel the service. So he wasn't going to try to police the person without a mask, but he was just going to stop the service and tell everyone to go home. We may encounter some of those situations. I don't know what we'll do. Honestly, I don't know what I'd do either in that. Please provide recommendations for software or other type systems to manage volunteers and register for worship services or other activities. Well, one is Zoom. Actually, you can still use the registration part of Zoom if you wanted to for this, but there are others. I've actually heard a few places are using what restaurant reservation systems software. So you make a reservation to be there ahead of time. This would work for the child care that Judy was talking about, but also I think some of the larger churches may have to use it for the service itself to see how many might want to come. And I've already heard of a protocol one church is using where they're going to do something like that, but they're going to leave about 10 open spaces so that they can be hospitable to people that might not have registered and show up, so they can keep the number down. I will have our communications people look into exact software that might be available for that. I don't have any right now, but we'll certainly try to do that. In terms of liability, what record keeping should we do to be able to prove that we have followed the required protocols? That's an attorney question. I don't know.
So one would be actually having the protocols documented and having them in a single source. The second would be acknowledging the training. So keeping a record of who was trained and who was provided copies of those protocols. And you could go a step further in having the recipient or volunteer acknowledge that they've read the protocols as well. So that would be 3 different ways to document it.
Okay. Are we still recommending that all blankets, stuffed animals, toys be removed from nurseries and other young children areas? Yes. Yes, as much as possible, yes.
Yes, yes, and it's really any toys. That's why we're removing books, right? Because it's things that can't be wiped down and disinfected.
Thank you. My understanding from the 4-phase plan is that childcare, Sunday school, et cetera, should not be resumed until phase 3. Is this correct? Yes, at least phase 3. And again, you can decide after that point whether you still want to, but that is correct in our plan. Has church insurance made any new provisions for parishioners returning to church and our insurance policies? Ironically, I'm in the church board meeting right now that we're meeting, of course, remotely. There really haven't been adjustments in the actual policies themselves. CPG is putting out lots of information and recommendations and trying to be helpful to that, but there are no major changes other than that. And you know, they're fielding a lot of the same legal questions we're having, and they're getting and giving the same answers, that whatever protection we would have under any other liability, we would have that protection with our insurance, and they would try to process that as best they could with the new law and new precedent that will be set as we start seeing some of those lawsuits. But that's really the best I think I could say on that one. What constitutes, quote, adequate coverage? I'm not exactly sure what that refers to. Probably insurance. Can somebody answer that one?
I think that, well, it depends. I mean, it really depends on the size of your church, the nature of the building. There are factors that go into that, but I think the general amount that I've seen for nonprofits for liability insurance is $1 million, but that's creeping up to $2 million. So I'm seeing more $2 million policies than I had seen in the past, but $1 million for sure.
Yeah, $1 million's the number I typically hear too. It was suggested by 2 retired attorneys in a meeting this morning that churches should ask attendees to sign a waiver. We've answered that. Yes, yes, we should, and we probably will. How long should we keep the forms? We have forms for the last 3 months. Well, we've answered that too. 21 days is probably long enough, but maybe 30 would just be safe. What safe sanitary way is there to have a sign-in sheet? We've just tried to answer that as best we can. How can we best handle visitors who have not received advanced communication about our requirements, particularly folks who are homeless or not practicing social distancing, hand washing, and mask wearing? I think the best thing you can do on that is to, whatever kind of system you have for making sure you're below the number, if it's a reservation system, like I said, cap it off so that you have some leeway to allow people to just show up, come in. And you have to have the hand washing and the masks prepared for them to have if they don't have them themselves. And the person asking this, I happen to know that you do because I've been there with you and you do a great job with this. So that's, I think, the best we could say about how to do that. There are going to be those situations that you probably haven't planned for and we don't quite know how to deal with. And I hope you share that with us so that we can all learn from that and we can share it too.
Can I
yes, yeah, please.
I just want to go back to the waiver situation. We've been sort of talking about whether waivers are a recommendation or not. And I think that having appropriate protocols written down and appropriate training and all the pieces we've talked about to show that you're doing everything that's reasonable to prevent people from being contagious and getting the virus is really the most you can do, and that a waiver, walking into church and signing a waiver really isn't, I don't know, I just haven't come to a conclusion about that. So that's something you might ask your own chancellor about to see if that's something that that person would recommend that you do. But I think having appropriate protocols in place that you appropriately enforce is as good a defense as any. But Steve and Bryan, please feel free to disagree with me on that.
Judy, I think that's accurate. And one of the things I think that's really critical that sometimes we don't think about is signage in the congregation, whether it's posters or announcements, and not just that you have a sign, but is it placed in a way that forces people to look at it? So one of the things, as an example, at our firm, what we've done is when you come off the elevator, there's an easel that has all the CDC requirements for entry right there that the client has to walk around to get forward. So it's not just that you have a signage in the midst of a bulletin board with a bunch of other signage, but there's clear communication. So, you know, you've got those protocols being communicated in a very clear and transparent way.
Thank you. Next question. If our clergy, rector, deacon has health issues that put them at risk, how can we address that without crossing their confidentiality rights with congregation? One reason, I mean, one thing I thought when I read this is we have confidentiality rights. I didn't realize we did with our congregation, but maybe our attorneys will let us know. I think it's going to be difficult if the decision's made that you can't be present. I think that's going to have to be disclosed for whatever reason for us to work through it. But I don't know. I'll let the attorneys have a run at it.
Well, it may need to be disclosed to you, the bishop, but it may not need to be disclosed to the congregation. And maybe the congregation just needs to know that there's some factor that makes this person highly at risk, and that the exact thing can still be private information if that's important to that person. That's that issue around transparency that's really difficult in churches and in nonprofits. But certainly a person with respect to private health information, I believe, does have a right to keep that confidential. The fact that there is something would have to be disclosed in order to appropriately mitigate it. But you wouldn't have to know if it was lung or a liver or something else.
Right, right. I like that answer. Next, keeping confidentiality about who has contracted COVID-19 will be a challenge. Any suggestions? Well, I would say for leaders, I'm going to say just do it. You keep confidential about many things. You're going to keep that confidentially too. If lay people know about it and spread it around, there's not a whole lot we can do about that. But you know, we ought to be fairly good at this game, especially if we're ordained, of keeping things confidential. Any other thoughts from the panelists? I don't know what else to say. Just do it.
I would say that there are a lot of rumors that, I mean, I've experienced this at our firm. There's rumors about who has it, who doesn't have it, and I think the anxiety is high because of that. So keep that in mind as you find this information out, that just because you think someone has it doesn't mean they necessarily do have it. And that's why the confidentiality can be very important.
Great. The next question has to do with 60 or 65 for, I believe, the fourth or fifth time. It is 65. 65 is the age. Will diocesan guidelines dated 5/7 be updated to be consistent with the state-issued requirements? No. We're not going to do it because we be doing it every single day. Instead, what we do is we refer back to that document as a kind of a baseline, and we take the memos from the governor and put those out on a regular basis. It's important for that reason that someone locally, your clergy gets this every time, but that someone locally, especially if you don't have clergy at the time, are receiving the communications from us as we try to update those memos as they come out. But this changes so often that updating that document is not going to be something that's even fruitful to do. What I've done, and I'm open to do this, that's what I'm here for, is to talk with you, anybody at any local context, to try to work through what it is you might be dealing with there. I spend a lot of my day doing that, and I think that that's exactly what we should be doing. So if you have a question or confusion about what the governor is saying and what our document says, just let me know and we'll get that answered. A nightmare scenario that some of our vulnerable population have already expressed is there are some individuals who, when and if given the opportunity to return with protocols in place, are planning to be non-compliant. This places our ushers and greeters in a position of serving as police and potentially risking physical harm. What would you advise? Well, yes, I totally agree with you that could happen. I'm going to say that I think this is the tough place where rectors and leadership, lay leadership, are going to have to decide what you will do when that happens. If masks are ultimately important to you and a person just adamantly opposed to it, and I agree with you, we've already got a tenant situation in our diocese that the congregation just is adamantly opposed to masks. And we're considering just letting them out of their lease or telling them to go meet somewhere else, because our expectation is they are going to live by that. And that actually is part of the governor's guidelines at this point as well, regardless of what they think. So I think you've got to decide, maybe like that priest in the other diocese, that if that happens, we're going to, for the safety of everyone, we're going to shut it down. I think we're going to encounter some of those kinds of things. I don't have any authority, especially with lay people, to do anything to them if they do that. And this is where it's, I hate to be unhelpful to the local, but this is one of those situations you're going to have to handle locally. We'll help you in every way we can. But I think thinking through that scenario and what you're going to do if that scenario occurs is very important to do, and not to assume it's not going to happen. Other anything else? Or?
It seems to me that it's a vestry decision. The governing body needs to decide, and that the church has the absolute right to prevent someone from entering if they don't wear a mask.
Yep.
So I think it's important to understand that you have that power, and then you need to decide whether you're going to wield it and how you're going to wield it.
Thank you. I'm going to just disclose that our questions are not going down. They keep going up, but and it's 4 o'clock. I'm going to try to get through these. I'm committed to try to get through these. Some of these will be redundant. I think our panelists will have to decide if they can stay or not. I'll try to stay with you and answer them as much as I can. But I understand if some of you have to go, because I think we did cap this off at 4 o'clock, if not at 3:30, and we're at that hour. So if you've got to go, that's fine. I'm going to keep plowing through these. And, if we do not get to all of them, we'll try to answer them offline or make a decision as to whether they were answered in this. Can you address essential food and shelter programs in churches? Currently, we serve food outdoors, but that will need to change when the weather turns. What can we require of volunteers and guests who may or may not be able or willing to follow procedures? I don't think you can require volunteers and guests, but I do want to say that just because the weather turns, I may not be able to say you can have them inside now. I just want to be clear about that. When we get into the phases where we can allow that, that's what we'll do. But just because the weather goes bad, the virus isn't going to change. In fact, it's probably going to get worse. I don't know that for sure, but we hear that might be the case. From a legal standpoint, anybody want to answer that question?
Well, I think that your vestry has the ability to set rules for who can come in the building, and if wearing a mask or acting in other appropriate ways to protect other people is necessary to protect other people and keep it safe, then certainly there's an ability to have those requirements and not allow folks to come in who aren't willing to meet those requirements.
Next question, do we have the legal right to require contact information? I believe we do. We own the buildings, and as owners, we can require it. Is that correct? Yeah, I get nodding yes from the attorneys, yes. I saw a comment on a consent form or a sign-up sheet. Does a sign-up sheet imply that consent, or does it need to be explained when they sign it? Yeah, no, we can't trick them into signing a consent form or act like no. The sample we give you will have something on there that says they're consenting, realizing that we can't guarantee they won't get infected or something like that, and that they understand that and are voluntarily coming into the space, something like that. Our attorneys will be much better with that language than me, but no, you can't trick them into doing it, or it will be very clear what they're signing.
And I think you should, I think it's part of the communication with the congregation as well. So you might have it on your website and explain that everyone will be required to sign that when they come in now, and have some other communication up on the door or some other place that will be where it will be easily read.
Very good. If congregational singing is allowed, of course it's not. So let me answer that right now. Does that mean that we can have a sung Eucharist when we are allowed to begin having Eucharist again? No, not necessarily. We will make that clear. I would say probably when we finally do have, when and if we allow congregational singing, at that point, sung Eucharist will probably be okay. But right now, the answer to all of that is no. Will a comprehensive plan be drafted for the diocese that individual churches can use as a basis for their plan? Yes, we did that on May 7th. It's up on the website. It's already out of date, which I think you've already pointed out. And we're not going to update it, but we're going to give updates to it as we go along and as the governor comes out with his plans. In the document from the diocese, we see specific numbers less than 50 given for number of attendees, worship. I assume any parish gathering from the state, we heard that the cap should be a certain percentage of normal attendance. We should be following the cap of 50 for the diocese, shouldn't we? No, not necessarily now. If the governor changes it, like he did in phase 1, where he said 25% of capacity, then that's what I'll probably allow you to move to that. And that's what anybody that's in phase 2 that's asked me, that's the number we've gone with. So in most cases, especially around numbers of gathering, we will follow the governor's guidelines on that. I'm still reserving the right that we may have specific cases and instances and practices where we will have to address that because the governor doesn't. But by and large, especially when it comes to numbers of gathering, we're trying to follow what he is putting out as the new guideline. Posters to download. Are there also other templates like screening surveys, etc.? Yes, and we will be sending those out to you as we put that together. That will be a link as well. Yeah, I'm not going to name this name, but this priest has named a person that I certainly know that's clearly saying that he will never wear a mask, and that's a risk to all in the gathering. Yes, I agree. And, like I said before, I think you've got to decide locally how that's going to happen. I'm happy to work with you on that because I don't want to leave you alone on it, but I'm saying I think you really do locally need to prepare for that, especially if you've already heard, which sounds like you have, that somebody's going to pull that. So, Steve, your audio broke up a bit on my end during your discussion of air turnover. I think you've answered that. Was it 10 times also effective as surface sanitation with UV light? Is that approved as a surface method?
10 times, and UVC is not in and of itself sufficient. It can be additive to surface cleaning.
Okay, great. Should we keep windows open during church services and meetings? I think if you could, that's a good idea. You get some circulation. I think that's a great question, and I'm getting nods from our medical expert that that's not a bad idea if you can do it. Recommendations for sanitizing fabric pews. That is a good question. I wondered about while we were talking. Is there any good way to do that? Get rid of them. That's one way. But maybe if you've been wanting to get rid of them, this might be your chance. But I don't know. Is there anything, Steve, that you think could work on that?
I have this vision of those 1960s sofa covers in plastic.
Exactly. That's what I was going to suggest, is something like that. Yeah. Because plastic can be wiped down.
That might be a sure way to get everybody on your side about getting rid of them. If you put that on there, that might work. Let's see, you wouldn't wipe down pews between services? Yes. Yes, you would. Yes. If you have a crowd in there and then they leave, you've got to disinfect it all at that point. In fact, I had a church ask me this week if with the 25% capacity cap, could they just open the church to people to come in and pray if they made sure they were social distance? My answer was, you could do that, but you're going to have it a human resource all the time, because when they get up and leave, somebody needs to disinfect that spot. You also need to make sure they're social distance. So if you're just talking about open the door and let them do whatever they want, the answer is no. But if you're willing to manage it and disinfect, then you could do it. But wiping down between the pews between service, you will have to do that. Is it a good idea to leave longer? Yeah, go ahead.
Can I just add something? I want to make sure that everybody understands that the CDC website that I think we've put in our resources and other health department websites have really good ideas for protocols. So that's a really good place to go to put together what kind of protocols you need to put in place in between services, for example.
Yeah.
Yeah.
Regarding deep cleaning, it's a good idea to leave longer periods, say 3 to 5 days between services and other building usage. Well, yes, if you can, but a lot of places are not going to be able to do that. And to mitigate against that, you just have to clean between each gathering, even if that's on the same day. Steve could comment, but I think the longer you leave a spot, yes, I've heard that it goes away, but I think you don't get away from disinfecting just because you let it sit there for 3 to 5 days. You still need to do it before you let people back in there. A number of commercial establishments I've visited lately are now limiting visits to restrooms to one person at a time. Okay, thank you for that statement. That's a good idea. That wasn't a question, so we'll move on. Steve, could you please send us resources for those taps, etc.? Taps? That's what it says, taps.
For taps. I'll have to check with our facilities folks who've got that information. I assume they're meaning the touchless taps and flushers.
That's what it seems like. Yeah, it's great. Yes, we'll try to find that and get it out to you. Thank you. It isn't clear to me what phase we are currently in. Well, you're not alone. As a diocese, you're in, wherever you are, you're in the phase the governor has declared for your county. That's the phase you're in. Then you can consult our document and the governor's document, but then you probably will need to talk to me about any nuances that you're unsure about in that. But we're going with what the governor has decided. If your county's in phase 2, you're in phase 2. If your county's in phase 3, you're in phase 3. Is your permission to move forward going to be granted on a congregation or diocesan basis? In other words, can congregations and counties in phase 2 be permitted to move forward, while others, yes. I think I just said that. And but yes, if you're in phase 2 in your county, you can move to phase 2. And so just do that. And if you have questions about the inconsistencies now in some of our documentation, just ask me and we'll get it straightened out. Yes, a person says, I called church insurance, was told no additional special coverage required, was told to check CDC requirements. And that is what they're saying. There are some aerosol generator devices that have been used in schools which allow a rapid sanitation of large areas. Have been very successful in reducing regular flu by 80%. I will get the link and send to you. They run about $1,000. Not cheap, but efficient. Thank you. Yeah, please send that to us and we'll take a look at it. Are there any ongoing discussions to create riders on church insurance policies? We just answered that. No, there are no plans for that. You're covered with what you have. What about touching your own mask in order to pull it down to receive communion? Yep. This is just fraught with all kinds of problems. That's still an issue. You then potentially have the virus on your hands. Yes. Guidance on protecting the health forms, as in HIPAA issues. I don't think we fall under HIPAA on this particular thing, but I'll ask the attorneys about that. These are not medical procedures we're doing. This is just a consent to enter a space and a consent to answer a few questions that we are requiring for you to enter. I don't think there's a HIPAA issue with that.
I don't think any of the questions ask information that would be HIPAA covered.
Yeah. Right.
It would be good practice just to keep the forms confidential and not share them with unnecessary individuals, and that goes to both privacy concerns of people who are attending. But
Yes, and so when you take them and file them, they should be in a file that remains confidential, so they're not open to people, normal, regular people.
Here it says CDC notes a 7-day suggestion. If the space is unoccupied for 7 days, we only need to do a normal cleaning. Okay, sounds good. Oh, and there's the link for the sanitation equipment. So we will capture that. Ron, you might need to email that to me in case we lose this chat. I would really appreciate that. Thank you. I keep thinking about communion, and the presider needs to be distanced from the bread while consecrating so that it isn't infected by droplets. Wear a mask during the Eucharistic prayer. Keep the bread covered until the fraction. These are questions. Stand back from the altar, have the bread pre-broken, and place in individual serving cups on a table. Egad. Okay, I'm gonna let the dean answer that, both from medical and also he's been doing this on virtual worship. So what are your thoughts about all that?
I would say talk with your bishop before you deviate from his. But certainly good hand washing before the presider goes into the Eucharistic prayer. Avoid raising the bread in front of your face if you're one that elevates. Try to avoid touching the bread as much as possible. And if at some point you're sharing the bread, figure out how to do so socially distanced. Leaving the bread on the side of the altar table for each person to come individually or some such like that.
Thank you. I'm a priest well over 65 and missed the rationale for the cautionary measures. Is it simply because the age is considered more susceptible? Yes, basically. Most people that are dying in the ICUs and are put on respirators are people 65 and over. Still, even though we've learned clearly young people are susceptible to this, but the vast majority are people 65 and over, and that's what it's about. It's not anything different than that. If someone tries to attend a service without wearing a mask, do we have the right to refuse them entry? You do have the right to. You may not have the force to, and I'm asking you not to use force and to maybe expect that this might happen and to come up with a protocol locally about what you're going to do if it does. That should not include weaponry or anything like force. So this is a very difficult situation. It is, but we've already heard there's even a named person who intends to try to work this out. So you need to come up with it locally, and I'm happy to work with you locally on that specifically too, if you want. Could we send out a consent contact form to people ahead of time and then have them bring that to church? If it's the one you're using at the doorstep, I wouldn't see why. I mean, if they forget it, they're still going to have to sign it when they get there, but you could do that, I think. I don't see a problem with it.
And I would just caution that it needs to be completed the day of presenting to the church, not 48 hours or 72 hours before.
Yeah, that's a good point. That's a good point. Hard to social distance if people are lined up for screening. Well, I think what you mean is screening at the front door. It's not hard. Grocery stores are doing it. Restaurants are doing it. The airport's doing it. If you need help on how they're doing it, I'll be glad to show you, but it's not hard. It's going to be hard to enforce it. Maybe that's what you mean. But I think we just have to keep asking and keep imploring people that we're doing this for the health of everyone and out of love for everyone. But you could put X's with tape and say, have people stand on this before they sign up. There's lots of ways to do it where you make sure that they're 6 feet apart. Should AA get a pass or have them maintain their own records? No, I don't think they should get a pass. The virus doesn't give them a pass. And we're not giving them a pass either. And in fact, many of the AA groups that I've had interaction with have actually been very amenable to this. They want to stay safe too, and they're trying to do it the best they can. They can, you then ask, can they maintain their own records? No, because if the authorities come to you and ask you who's been in the building and where are the records, you can't, you really need to have them. So they need to be giving the records to you. They could do what you're asking to do. In other words, tell them how to do it, what the protocol is, that you've got to keep these records. And that's another reason why they need to be kept confidential. They're for your records, not to share with anyone else, but for you to be able to produce them for authorities if an infection happens. And, you know, if that's uncomfortable for anybody, they're really going to have to individually decide whether they want to come to that space if they have to do that. And I know that that's difficult, but we really can't give them a pass on this. How soon will the one-page document, the questionnaire and consent, be available for congregations to download? How soon do you think we could have that?
I think by Friday is, I should be able to.
Okay. Do we have to have a sign-in system if the service is outdoors? According to the guidelines I've read, yes. You still need to keep track of who was there. You know, even though outdoors is better, many of the spikes lately have been outdoor events where people didn't keep distance. They thought that they were excluded somehow because they were outside. You still need to do the screening for an outdoor event. Recommendations on air system engineers.
I'm going to take off. I have a 4:30. So thank you so much.
Thank you, Judy. Thank you so much for this presentation. I really appreciate it.
Thank you. Thanks for including
for all
me.
you do.
Bye.
Anybody here got recommendations on an air system engineers? I have to be honest, I do not.
I would just recommend that you contact your regular service provider, your HVAC service provider. They will have an engineer. It won't be your regular service person, but they will have an engineer on staff. They're required to by state law, I believe, and it will cost something, but it will be well worth it, I think.
This is the question: would you close with reassuring that this is a team effort to reentry and should not be the sole responsibility of one person? For example, the parish administrator of this person is one, that's why they're writing this, I'm sure, or the priest. And you just did, and yes, there is no way this can be done by one person, all that we're talking about. So it's got to be a group effort. When will you be update to the guidelines that incorporate the information given today? Well, as soon as this webinar is posted again, you will be updated. And also we will be putting the slides and the various other links that we've said out first in a constant contact newsletter, but then also posted to the website. So they'll be updated that way, but we're not updating the document, the gathering document. Sanitizing dispensers are dirty as soon as one puts their hand on the pump. Suggestions? Doesn't look like anybody's going to take that one. No,
Well,
we live in a dirty world.
It's part of the deal. But if you're squirting it on your hands, then theoretically your hands are going to be sanitized. You could go to touchless; they're more expensive. You could also offer sanitizing wipes, and I carry a wipe around with me when I'm in the building. I don't touch a doorknob. I have the wipe touch the doorknob, so forth.
Thank you. I'm going to say this just one more time today. You do not have to move to the phase your county's in unless you have decided there that you want to. You are allowed to move to the highest phase that you are, but you are not required to. Yes, consent forms will need to be done every time. So it doesn't matter that you filled one out last Sunday. This Sunday's a brand new Sunday with a brand new crowd of people and a whole different mix of people. It has to be done every time you enter the church. Yeah, there's a point here that the one taking the temps is not social distanced. That's a good point. I hesitate to say this because people will always say, well, that's what you said. So let me be clear with what I'm not saying. I'm not saying we're not going to do that, but I am saying we're considering not doing that. Temperature taking has been shown to not be super effective with this anyway, but I'm not at that point yet where to say not, but it could happen. So please know that at the moment that we're still thinking that will be required, but it could be one of the considerations that's dropped. You just won't believe this. We're down to 2 questions, maybe 2 people too. I don't know, but has the use of fans been discussed? Do they spread the virus? Well, I think if you saw the air circulation slide that the dean did, I mean, air circulation certainly has something to do with this. I mean, there's a lot of evidence to show that, but I'm not sure I'd know where to put the fan for the best result. That would be my hesitation. What do you think?
Air movement is good, but alone is insufficient. If you're just circulating stale air, you have to assume it's contaminated air, which is why the engineer helping you with whatever the filtered ventilation system is going to have to be a part of it.
Last question. What about accompaniment books for pianists, organists, instrumentalists? Well, I would say we really, in these first phases, want to stay away from books at all, if at all possible. And if we are using books, that they're only touched by one person. We really need to try to do that. There are no more questions. I want to thank our panelists, and I want to thank all of you for showing up for this, for your dedication, for everything you're doing locally. I think the proof that you hung in here shows just how seriously you're taking all this, and I really appreciate that. So thank you, Bryan. Thank you, Steve. Thank you, April and Carrie behind the scenes, and bless you all. And we will have this recorded. We will have it up so you can share it with other people and also watch it again along with all the links. And if out of this we think there's some need for another webinar, we'll try to put that together and get it out to you. Thank you. Bless you, everybody.